How
Yes,
about
that's
you?
good now, Virginia. Yeah. Um, I think we are set up to start. Thank you all for coming. Today we have Virginia presenting on her thesis. This is the continuation of the rehearsals, the practice presentations for the track students. Thank you all for coming. Virginia, you can take away whenever you're ready. You're muted, Virginia, just so you know.
I'm sorry, Joe. I don't know. I'm getting a certain challenge here. I'm trying to troubleshoot.
Okay.
Just it.
Do you want what is happening? Maybe I can help.
Just 1 minute. Do you still see the presenter mode?
Yeah. Um, maybe what you need to do is to have the presenter mode on before, and when you share a screen, maybe try to select only the other window. Maybe that's possible. So leave it on like that, and now try to share only the slides, see if that works.
Sorry, can Miriam start? I think my laptop is also a bit stucky. That's why I'm facing another challenge.
Okay. Miriam, do
Yeah.
you think you could start this time around?
Yeah, sure.
Okay. I think I need to make you co-host. Give me a second. If I can. I can't. Let's see, can you make Miriam co-host so she can share? Uh,
Can you all see my slides?
Mm-hmm.
Okay. Good morning and good evening, everyone. My name's Miriam, and I'll be taking you through my thesis titled Trends and Predictors of Prolonged Length of Hospital Stay among Surgically Treated Orthopedic Trauma Patients in a Tertiary Hospital in Northern Tanzania from August 2020 to March 2025. These will be my outlines, and these are the acronyms I've used. For PLOS, meaning Prolonged Length of Hospital Stay, and KTS is the Kampala Trauma Score. For the definition of key terms, length of hospital stay for my study, it has been defined as the total length of time a patient stays in an hospital for the purpose of treatment. It has been measured in days from the date of admission to discharge or death. And prolonged length of hospital stay has been defined as length of hospital stay above the 75th percentile of the entire study population. For orthopedic trauma, for my case, it has been used as trauma as fractures. And in the introduction, globally, injuries account for 4.4 million deaths. And of these, it is projected that almost 8 trillion USD will be lost globally from the year 2015 to 2030 due to trauma. But still, length of hospital stay remains an important measure of health system efficiency. Of all trauma that will occur globally, more than 90% of injury will occur in low and middle income countries, and economic burdens, more than 50% are projected to occur in low and middle income countries. And each year, more than 1 billion people are hospitalized each year for treatment of an injury. In Tanzania, there have been reported to be a 36 growth in orthopedic burden from the year 2015 to 2018. So USA, high-income countries have a mean length of hospital stay of 3 to 9 days, where studies that have been done in Australia show that PLOS has reported to be 9.7%, where it was taken to be greater than 14 days. In low and middle income countries, the mean length of hospital stay varied to 10.5 days in India and 14 days in Nigeria. But PLOS has been reported to vary between 25.3%, 26.5% in Ethiopia, where length of hospital stay was taken as 14 to 33 days. In Nigeria, where they took PLOS to be greater than 7 days, the percentage of PLOS, the proportion of PLOS was 63%. And in Tanzania, at KSMC, studies that have been done, they have shown that the median length of hospital stay to be 6.1 days. This is among trauma patients. And another study that was conducted at KSMC showed that the mean length of hospital stay was 13.5 days, but this was for all trauma, for all orthopedic diseases. So we still have limited data on PLOS, and especially among orthopedic trauma patients and their predictors. Understanding these predictors can help us improve care among these patients. So this is my conceptual diagram where sociodemographic factors have direct influence to the prolonged length of hospital stay, and also sociodemographic factors influence the clinical characteristics, which have a direct influence on prolonged length of hospital stay. Clinical characteristics have an influence on the referral status, which have an influence on prolonged length of hospital stay. Also, clinical characteristics affect complications and the number of surgeries that a patient has to undergo, of which all these affect prolonged length of hospital stay. So for my problem statement, orthopedic trauma still remains a major cause of hospital admissions that require surgical care, and prolonged length of hospital stay after surgery causes multiple challenges. In low and middle income countries specifically, it increases the direct and indirect costs for patients and families, and also leads to hospital overcrowding in an already constrained setting. And also, prolonged length of hospital stay increases the risk of complications such as hospital-acquired infection and pressure ulcers. But still, there is limited evidence on what are the drivers of longer hospital stay in low and middle income settings. So this study will guide better planning in orthopedic trauma care and hence reduce financial hardships for patients and families, improve hospital bed capacity, and avoidable medical complications. It will also help understand predictors of prolonged length of hospital stay, which are key to informing the discharge planning, streamlining perioperative care, and supporting targeted interventions. So my broad objective was to determine trends and predictors of prolonged length of hospital stay among surgically treated orthopedic trauma patients in a tertiary hospital in North Tanzania from August 2020 to March 2025, with specific objectives being to determine the proportion of this group, my second objective being to describe the trends, and my third objective being to identify the predictors that are associated with prolonged length of hospital stay. For my methodology, my study design was a retrospective cohort study with a data source being the KSMC Trauma Registry from 2020 to 2025, with my study area being the KSMC Zonal Referral Hospital, and my study population being orthopedic trauma patients who have been treated surgically from 2020 to 2025. My inclusion criteria was any patients who had a fracture and who underwent surgery who was greater than or equals to 18 years. Data cleaning and analysis was done using the R software version 4.4.3. So this is the flow chart where initially we had 4,013 patients, and after excluding patients who did not have fractures and who did not undergo surgery, we remained with 1,471 patients, of whom, after excluding patients who did not have a discharge or admission date, we remained with 1,465 patients who were used in the final analysis. For the independent variables, we had social-demographic characteristics such as age, sex, education, admission characteristics such as the admission time and referral status. We had the clinical characteristics such as the injury location, number of surgeries, complication, comorbidities, and injury severity. For the dependent variables, the dependent variable was length of hospital stay, which was calculated as number of days between the date of arrival and the date of discharge or death. And for the analysis, specifically, this length of hospital stay was dichotomized into prolonged length of hospital stay, which is length of hospital stay greater than 27 days for my case, which is above the 75th percentile, and the normal length of hospital stay, which was below the 27 days. So this categorization was used because we had a wide variation of injury types and severities that were in this study population. That's why it was chosen, and most of African countries employed this methodology to look at prolonged length of hospital stay. So for data management and analysis, the proportion and trends use the descriptive analysis. So the continuous variables use the median and interquartile range, and categorical variables were described using frequency in percentage, and Pearson chi-square and the t-test were used. For the predictors, I used the modified Poisson regression and significance level. The p-value of less than 0.05 was considered significant. For the results, the social-demographic characteristics, the median length of hospital stay was 11 days, with the majority of our participants being males who had non-formal employment and who had primary level. The highest form of education attained was primary education. For the marital status, 55.5% were married or cohabiting. Majority had no health insurance, which is 84.6%. And a considerable high percent, which is 23.8%, had used substance in the last 6 hours before the accident. So majority of our patients were referred, and majority did not have any comorbidity and did not have any complications. So most patients were alive by the end of the study, and most patients had mild injury, which is 55.4%, and majority of patients only underwent one surgery. So here we have 24.8% had prolonged length of hospital stay with a minimum of 27 days and a median of 42 days and a maximum of 369 days. So here is the figure showing the trends of prolonged length of hospital stay. We see there have been an progressive increase of proportions of prolonged length of hospital stay from 18% in 2021 to 38% in 2024. So this table shows a univariable and multivariable modified Poisson for the predictors. And for this, we see that patients who had health insurance had a 30% times lower risk of prolonged length of hospital stay compared to those who had no insurance, and this was statistically significant. For patients who had moderate injuries, they had a 52% higher risk of prolonged length of hospital stay compared to those with mild injuries, and this was also statistically significant. Patients who had complications had almost 2 times higher risk of prolonged length of hospital stay compared to those who had no complications, and this was statistically significant. And those who had multiple surgeries had almost 3 times higher risk of prolonged length of hospital stay compared to those who had only one surgery, and this was statistically significant. For those who had upper extremity injury, they had a 55% lower risk of prolonged length of hospital stay compared to those with lower extremity injuries, and this was statistically significant. And for those who had injury in the thorax and neck, we see they had higher risk of prolonged length of hospital stay compared to those who had lower extremity injuries, and these were also statistically significant. For patients who underwent surgery more than 48 hours, had a 34% higher risk of prolonged length of hospital stay compared to those who had surgery within 24 hours, and this was statistically significant. So for the discussion part, we saw that the median length of hospital stay was 11 days. This is similar to studies that have been conducted in low and middle income countries such as India and Nigeria, and it is higher compared to those studies that have been conducted in high income countries. So this shows similar low and middle income countries challenges such as surgical delays, weak rehabilitation discharge systems, and financial barriers that the patients have while seeking surgical care. So in this study, also we have participant factors that could contribute to a much longer length of hospital stay, where most of our patients were males, they were unemployed, and they were married, more pushing people to dependency and more burden of poverty, hence leading to delayed discharge. We see that the trends increased from 18% in 2021 to 38% in 2024. This could be attributed to both improvements and persistent challenges. So over the years, we have seen that there have been more orthopedic surgeons and EMD specialists. There have been better patient capture through this the KSMC trauma registry, and there have also been the cultural shift where most people want to be treated in specialized centers. But still, there is persistent challenges that at KSMC, we only have two designated orthopedic operating rooms, and there is a rising patient volume that exceeds this infrastructure, leading to surgical delay that can prompt longer stays. So for time to surgery, surgery greater than 48 hours increase the risk of prolonged length of hospital stay, and these delays in our settings are often due to structural and socioeconomic factors. So for structural, we have fewer surgeons compared to the burden of patients that come in, and we have limited operating rooms as explained earlier. For socioeconomic factors, still patients face financial constraints towards paying for their surgery. So as for other studies also, it has been shown that timely surgery improves outcomes and reduces length of hospital stay. For insurance status, we saw that patients who had insurance had lower risk of prolonged length of hospital stay. This could be due to that investigations, treatment, and discharge are done timely for those patients who have insurance compared to those who have to pay out of pocket. For the injury severity, we see moderate to severe injuries had prolonged length of hospital stay compared to mild injuries. But for our case, we see that for severe injuries, it was not statistically significant, and this could be due to early mortality in severe cases and low pre-hospital survival. For anatomic site of injury, the neck, chest, and back fractures had increased risk of prolonged length of hospital stay, while upper limb injuries had lower risk of prolonged length of hospital stay. This could be due to mobility and early discharge among these patients who have upper limb injuries. For strength of my study, this study focused on surgically treated orthopedic trauma patients, hence increasing clinical relevancy. And it had a 4-year trend analysis that has captured changes in hospital capacity, workforce, and care system. But it also predicts and supports planning and system improvements over the coming years. For the limitation, it was a retrospective design where we have risk of missing or misclassifying data, and we had no data on pre-hospital delays, and we also had lack of clinical predictors such as hemoglobin level and creatinine. So for the conclusion, we had an increased trend in prolonged length of hospital stay over the 4 years, and the key predictors were surgery more than 48 hours, injury severity, complications, anatomical injury site, multiple surgeries, and lack of insurance. So the recommendation to the hospital administration and Ministry of Health to prioritize timely surgery within 24 hours. This could be done by expanding operating rooms and improving surgical system efficiency. Also strengthening district and regional hospital capacity. This will help reduce referrals to tertiary centers like SMC. Also help
Oh
patients.
my words.
Also
Yeah,
help
and that's, you see,
patients
that's
get
kind of stress.
treatment close to where they live and enabling discharge planning more efficiently. To policymakers, expand health insurance coverage. This will be done through simplifying the enrollment, also offering low subsides to people from low income households, also using community healthcare workers for public awareness. To hospital administration clinical teams, prevent post-surgical complications. This could be done through implementing daily multidisciplinary rounds, adapting the ERAS protocols, and improving communication. Future research should focus on surgical quality, where it should evaluate intraoperative practices and post-op care, identify gaps, and improve outcomes and reduce prolonged length of hospital stay. These are my references, my acknowledgement, and thank you for listening.
Thank you for the presentation, Miriam. I wanted to open up for folks to share a few questions. Maybe if we can look at the chat, we have a few comments from William, from Alice, sharing a few suggestions. But if anyone else would like to clarify or to ask questions, we have a few minutes that Miriam could use.
So, Miriam, I'm going to ask you a few questions just to jumpstart here. How did you end up deciding close? I missed it because of my connection.
Okay, so I ended up deciding it because we had a wide variety of injury types in this in this registry, and so to ensure that almost every injury is captured, most literatures that have been done in the low and middle income countries, where they use the variety of different types of conditions, use the 75th percentile as a cutoff point.
The 75th percentile of your own distribution.
Yeah.
Okay, and that gave you the value of?
27 days. So those who stayed, normal length of hospital stay was considered less than 27 days, and plus was considered as 27 days, for my case, to 369 days.
Okay. Yeah, I think your presentation is, there's a few mistakes on the tables that I would like you to revise. There's some areas in the table where their numbers, there seems to be something wrong. So just review all your p-values and odds ratios, or the ratios you're reporting out. I think the main the main issue with your thesis is the definition of close. I think you need to make a good argument that this number that you're assuming it's close is not how it is comparable. Because when you say the argument that normal length of stay is up to 27 days, it sounds weird to me because it seems like a long term to be considered normal. So you got to be careful with the wording you say, because you're making a dichotomization, which then fits your analysis, but it doesn't necessarily might represent normal. And a good basis to discuss if it's normal or not might be something for you to think about, because it might be a question you get when you're talking about this. Instead, I would probably keep the close definition as higher than 75%, but I wouldn't call anything below that normal. I would call everything below that not close or something, just a different nomenclature, because yeah, it just strikes me wrong than normal.
Okay.
And that comparison with the literature and what close is in other literature, how that compares to yours is going to be important to mark if this is way out of charts or not. And I think that's the same comment we gave you the first time you presented this around. And in this presentation, I still think it might be a point of criticism to you. But overall, the rest seems very well done. Congratulations.
Thank you, John.
Okay, I want to thank again Miriam for presenting, and I want to have some time for Virginia to also share and go through her presentation. So maybe we can switch if Virginia is ready, and folks can keep sharing suggestions in the chat as well. Oh, I don't see Virginia online. Let's see if we can WhatsApp her.
Well, while Joao's doing that, just again, commenting, Miriam, just to make sure you see the comments in the chat. If you have any questions, I'm sure you can reply to those comments from William, Alice, Edwin. Really helpful information. Thanks everyone for the feedback. And I'm butting in because this isn't my show to host, but since we're waiting, wow, Peter, do you think we could open if there's any other comments for Miriam or any questions from Miriam herself, if you have any doubts or uncertainties as you're coming down to the final moment?
I have a quick kind of curiosity question. Excuse me. Hi, everybody. This is Noah. Miriam, this maybe doesn't relate so much to your data analysis, but I'm just curious. You mentioned that insured patients have a shorter length of stay than uninsured patients, and I'm curious how payment works at KCMC. Is it government funded? Do any patients get care without out-of-pocket cash or personal insurance? Because I mean, based on our experience in Botswana, that is an enormous driver of extended length of stay for surgical patients, especially orthopedics, where frequently hardware has to be purchased, and often that involves the patients needing to come up with cash.
Okay, so for our setting, it depends. if you are insured. So we have insured patients and we have out-of-pocket patients. So if you are insured, and there are types of insurance. There are insurance that can cover almost all investigations and the surgery, and we have insurances that only cover some things. So if you are insured, for our case, if let's say you have NHIF, which is the National Health Insurance, you are able to access investigations, the surgery in a timely manner. But if you're not insured and you have to pay out of pocket, then you and your family have to gather the money and bring it and pay, then you receive care.
That's really interesting. I mean, one kind of maybe future direction for this might be that, if you can show that delays in payment by insurance leads to poorer outcomes, it would be an argument for insurance companies to try to create mechanisms for more prompt payment.
Okay, thank you, Noah.
Great presentation. Really good project.
Thank you.
We'll hang tight. Any other comments, or did anybody who left something in the chat want to clarify or say more about what they added there? Alice, Edwin, William, or anyone else? Feel free.
Yeah, Miriam, I think you did an amazing job. You are timely, some milestone. It's really nice listening to your project. It's quite a work you've done for the past 2 years. As I might have mentioned in the chat and you have seen, I was also concerned, similarly as Joao, like saying 27 days, less than that is an ignorance of hospital stay. Maybe that could be an area that you could try really to justify, because less than 27 can be 0 days. Okay, so that's a little bit too wide of days to really classify, and maybe it could be useful to model it as a number. For now, that's not on the table. It's just something that you have to have at the back of your mind. That might be a very long interval to classify. And again, you have patients with different conditions.
Mm-hmm.
The patient might have come with just a humeral fracture or a dislocation, it's an orthopedic trauma. The person who was with a fracture, they did nail, so we expect, of course, their durations to be different. So there's that about your population, but I believe that can be one of the restrictions, because you are always trying to work with the population so that your study can be easy. Another from me was regarding mostly about if you had it. I think you have it somewhere in your descriptive tables, like just to give your audience a picture of the population that you recruited for the analysis, like what type of orthopedic traumas did they have? How many of them have limb fractures, etc. That would be helpful. If you have it, you can include it, but maybe for the manuscript as an but otherwise, I think you have done the real thing.
Thank you.
This is going to be very amazing.
Thank you. I'll incorporate the days, I think, in the manuscript. I mean, the description of those who had PLOS in the manuscript. I have not gathered them because they were in screen form, but I'll work on them in the coming days after my defense.
Yes. One more thing. One more thing. So for the problem statement section, it's tradition. I find this one, that's where you're trying to sell your study. You have nice points, but if you can at least quantify in a way, at least put some citations even at the bottom when you're stating a problem, that would be, because I feel like you have them in your book and I know it. Try to quantify, like in the problem statement section. I think that would be really helpful. That makes sense.
Okay, thank you, Willie.
Folks, so I spoke to Virginia. I was able to reach her out on WhatsApp. She says her laptop is having some technical difficulties, so she's probably not going to be able to rejoin and present to us today. But please feel free to reach out to her if you have questions. She has already presented to us in a few different occasions, but it would be good to have a final week practice as well. And I'll extend this to the folks there in Tanzania, to the fellow track students. Reach out to her, see if she needs some help, some support, if she wants to rehearse. That's a good time for you to exercise the group mentality, to give support. I'm sure that she and all the folks that are preparing for defense can be quite anxious and worried about the process. If we don't have any more comments, I think we can adjourn for today and meet again next week.
I had one question if we still have time.
Sure, yeah.
This is maybe kind of a hypothetical type question, but I'm curious for these prolonged length of stays, if there's any way of knowing or even estimating the additional cost of a prolonged length of stay. So I can imagine a situation where the hospital system realizes, wow, it took 20 extra days for this patient to get surgery, and it was just because the family was trying to find the money to pay for the surgery. At some point, it may actually be cheaper for the hospital system to find a way to help pay for the surgery rather than continue to keep a patient in the hospital. And I think if there were a compelling way to show that to the hospital, it might be a way to incentivize them to help with payment or something. So I don't know if anyone has any ideas about that, but it could be interesting.
So for our setting, it depends, but if a patient is already well, let's say the patient is already discharged, but due to financial constraints, the patient remains at the hospital. Each day they have to pay approximately $4 USDs for the hospital bed alone. And as we know, most of our